So you're trying to change the way that providers think, and can you give an example of a typological thinking and how that's problematic, knowing now what we know about genetics?
So typological thinking is the term that I use to describe when physicians essentially think in terms of diagnoses. An example of typological thinking would be to assume that everybody who has pneumococcal pneumonia has the same illness, when in fact physicians who are in the trenches treating patients know that some patients tolerate their exposure to pneumococci and don't get sick at all. Others of them get desperately ill, and we know some of the variation and genetic variation that contributes to that kind of differences. That has to do with things that control the antibody system, the immune response system, and many other things. So we're beginning to sort of gather the knowledge that is necessary to recognize the key individual differences that determine why our patients behave in different ways, even though they have the same diagnostic label.
In your presentation, you mentioned the NHGRI project. Can you just tell us a little bit more about that and how that's going to advance personalized medicine?
So the one outcome of the Genome Project and the projects that were designed and funded by NHGRI to enumerate human genetic variation, namely the HapMap Project and the 1000 Genome Project, has led to the ability to interpret genetic variation much more robustly, and at the same time, of course, genome sequencing has gotten much faster and much cheaper. So, and strategies that have been developed largely by the pioneer work by the folks at the University of Washington, Debbie Nickerson, Jay Shenduri, Mike Bamshed, and their colleagues, have developed strategies for taking patients with rare diseases and using large-scale DNA sequencing, be it whole genome or whole exome, to find the variant that is responsible for that patient's rare disease. Now, the challenges generally can be summed up as follows. Each of us has a lot of genetic variations compared to the reference sequence. So the challenge is sorting through the variation in a particular individual who has a clinical problem and asking, amongst this large set of genetic variation, where is the one genetic variant that's responsible for that clinical syndrome? And as I said, there are strategies that are being developed to do this. And so NHGRI, and partnered with National Heart, Lung, and Blood Institute, have put money into a project that funds 3 centers across the country: the University of Washington, headed up by Debbie Nickerson and Jay Shenduri and Mike Bamshed; Yale, headed up by Rick Lifton and his colleagues; and a center at our place in collaboration with Baylor, so we call it the Baylor Hopkins Center for Mendelian Genomics, headed up by myself and Jim Lupsky at Baylor. And the 3 centers, Washington, Yale, Baylor, Hopkins, have as their remit, if you will, to find as many patients with these rare disorders and to use the tools of large-scale sequencing to help figure out what the problem is. And we all think that that's the first step towards better diagnosis and better management of these patients who may have rare disorders, but if you have a rare disorder, you got it 100%. So we need to figure out how to do better by these patients.
You mentioned also in your presentation that some of these genetic studies take large patient populations with one phenotype and put them up against another patient population without that phenotype, and that how this can lead to poor predictive value. How can we avoid this going forward, or what better processes can be put in place?
Yeah, well, you've covered a lot in one question. So what I was talking about are what are called genome-wide association studies, and most of those studies are done with an experimental design that's called case control. And in a case control design, what we do is we collect a large number of patients with a particular problem and a large number of individuals who, as best we can manage it, are in every way like the patients who have the disease, but the second group, the controls, do not have the disease. And then we ask, what genetic differences are there between the group that has the disease, the phenotype, and what as compared to the group that does not? And so we may find that a particular genetic variant is enriched, is more common